I am Dr. Matthew Fay, a GP with Affinity Care PCN and a PwSI in Cardiovascular disease and Anticoagulation. Today I'm going to discuss the assessment of those with blood pressure issues in a health system with restrictions due to COVID-19. These are my normal declarations. As you can see, to treat people with cardiovascular disease, we need to come at the problem from many different aspects, including lifestyle and smoking and other comorbidities. But today we're just going to focus on the blood pressure control. Reducing blood pressure reduces cardiovascular risk, and this is a linear relationship. So we can always improve somebody's status as regards their cardiovascular risk by reducing their blood pressure. And to a certain extent, our problem lies in at what point we wish to intercede. So how can we assess blood pressure remotely in a time of COVID-19? So in a patient who has a home blood pressure monitoring device, this is relatively simple. We can just ask the patient to remotely check their own blood pressure whilst in social isolation or social shielding and manage that patient in the normal way. If they don't have access to such a device, then we can still assist in their blood pressure management. Clearly, we need to ask about hypotensive symptoms. If somebody is suffering significant hypotension, then we must do our best to reduce those symptoms, and so we should reduce our intervention accordingly. If they have no hypotensive symptoms and on the previous blood pressure assessment their systolic blood pressure was at greater than 140 millimetres of mercury, then we need to increase our intervention, and we can discuss this with them over the phone. Clearly, if the blood pressure was acceptable on last review and we don't have access to being able to monitor their current blood pressure, we should just reassure the patient, try and support their adherence to therapy and move their review date 6 months, hopefully to a period when our restrictions will be starting to lift. So how should we treat the blood pressure, even in a time of COVID? But these rules are true at any time. Well, we know from various studies, I'm demonstrating SPRINT at this point, that the lower the blood pressure, the better the cardiovascular outcomes. However, we need to think about how low can we go, as we know that if we go too low, then we can also cause issues with falling, with acute kidney injury, hypotension, and this can cause disruption to the patient. So we have this U-shaped relationship. In the SPRINT study, it was suggesting that a home monitored or an out-of-office blood pressure of 120 millimetres systolic was acceptable, and that would equate to about 130 millimetres in a desktop reading in the office. So we need to come up with a simple algorithm that our clinicians can follow to manage blood pressure appropriately. And so this is what we use at Affinity Care, starting with a dihydropyridine of your choice and then adding in an ARB after the first dosing of the dihydropyridine. We chose not to increase the single agent because this seems to provoke more side effects, and we thought that 2 agents would be a more appropriate action. Over the course, you can see that we continue to increase the medication. Our third agent, a thiazide, goes in, and then after patients are on triple therapy of an ARB, dihydropyridine and a thiazide, we would consider spironolactone. Getting beyond that 4th agent, we would also always recommend that we discuss the case with a cardiac colleague. Clearly, there are comorbidities where the assessment needs to be considered further. So in somebody with type 2 diabetes, clearly we should think about the ARB first. And again, in people with significant kidney disease, we should think about the ARB. We also consider changing the dihydropyridine to diltiazem in those people with CKD, as we know that those with proteinuria do better on diltiazem. In the case of those with known LVSD, again, we want to consider the ARB, and we'd want that ARB up titrated to its maximum dose. At Affinity, we use candesartan, and the maximum dose in heart failure would be considered to be 32 milligrams. Of course, we would also wish to use beta blockade in those with LVSD, and once we have them stabilised with both their ARB and beta blocker, we would then add in a MRA, and ours is the one we usually use is spironolactone. We're aggressive in our targets because we're trying to desperately reduce the cardiovascular load for our patient, and so we do not follow the NICE guidance of 140 millimetres of mercury for desktop readings. We try to achieve 130 millimetres, and if somebody's going to be monitoring themselves at home, we would take that down into the 120s. We're very proactive at trying to reduce their stroke risk, and we would promote statins as well, and I'll discuss this a little bit later in this presentation. When treating anybody with hypertension, as I've already alluded, it is vital to consider the consequences of overtreatment, and to those ends we are aggressive in our discussion with the patient to ensure that they do not have hypotensive features. And of course, anybody who's been stabilised onto blood pressure medication will require regular reviews of their electrolytes and renal function. We also do other parameters to look at the ongoing cardiovascular risk factors, so we invariably will include an HbA1c in their annual assessment. Of course, those people with hypertension or other forms of cardiovascular disease are also at risk of atrial fibrillation, and if this is found in a hypertensive patient, asymptomatic or otherwise, you would need to consider oral anticoagulation. Using the CHADS-VASc schema, hypertension would receive 1 point, and according to the current NICE guidelines, that means an anticoagulant should be considered. To further reduce their cardiovascular risk, we need to give some consideration to statins. And again, Affinity Care has a clear protocol along these lines. We know that we must always address lifestyle, and that is always the bedrock of good cardiovascular care. If somebody's Q risk is less than 10%, then we would leave them with lifestyle alone and ongoing assessment every 3 years. As soon as we know they are carrying significant cardiovascular risk, we would offer 40 milligrams of atorvastatin, recommending that this is taken at night. As that risk increases, with additional risk factors such as type 2 diabetes or CKD, then we would always consider offering a higher dose statin and increasing to 80 milligrams, as of course we would always use with those people with known occlusive disease. When we use statins, it is important to consider what to do if people suffer from side effects. We have a clear protocol that takes the clinician through the idea of a statin holiday for the patient, as we know if we remove the statin for several weeks and then reintroduce it, we can find that people can tolerate their statin better. We also have a clear pathway that if they suffer further side effects on the reintroduction of the atorvastatin, then we would move to a rosuvastatin, appropriately dosed for their level of risk. So what can we do when we contact the patient remotely to manage their cardiovascular risk? We should not forget the basics, encourage a better lifestyle, and take the opportunity to stop anybody from smoking if that is found to be a problem. We should take the opportunity to reduce the find the risk factors of cardiovascular disease. Take an opportunity to do a pulse or teach the patient to do so. Do a blood pressure, hopefully with home monitoring or with a device in the practice. Always discuss the risk factors with the patient and try to reduce them as much as possible. Remember that prevention is always better than a cure. Thank you for your attention, and if you would like any of the pathways of Affinity Care, please feel free to contact me at the shown address. Thank you.